This is going to be an interactive discussion amongst three great panelists around rural healthcare priorities and possibilities, and going to talk about the unique challenges and opportunities also in serving rural communities. Uh, and they're going to explore what are some current priorities in rural health and some areas of urgency, and also their thoughts, which I think they bring significant knowledge to on innovative approaches to and strategies to improve access and outcomes for rural populations and plan for the future. Myself, I'm the Senior Policy Director at the Institute of Health Economics. Wanda Aubee is so pleased that she was able to attend as a governor and a system a designer and accountable for a lot of the services that go. She's Assistant Deputy Minister for Primary Care and Rural Health for the province of Alberta. And Dr. Kimberly Hogarth, and like to congratulate Kim on her appointment as Chief Nursing Officer with Primary Care Alberta, which I think is just recently in the past while, but I think a really important and going to be an ongoing important role for how we roll out and deliver primary care. And we also have Dr. Ray Markham, who has done a major effort, I think, and as executive director for the Rural Coordination Center of British Columbia. Practicing primary care physician provides a lot of leadership, and I think in a sustained network that's really done some excellent things in the province of British Columbia. So this will be an interactive discussion. There are no slides. I encourage people to populate in the chat if you have questions that come up. We're going to have an interactive discussion, and then at the end be able to get to people's particular questions and comments that they might have. And so I'm going to start, and certainly we'll be able to asking questions of each other, but I'll be trying to moderate here. And just first to Wanda, what innovations do you think are urgently required in the governance and organizational structures in rural healthcare?
Thanks, John, and good morning, everybody. Thanks for joining us today. So this is a great question, and as you introduced me as a governor, I don't know if anybody's ever called me that before. I was thinking about how I would answer this type of a question. So, from the government's perspective, obviously we have a significant amount of change going into how the system is structured through our health system refocus efforts. And so the really effective operations of those agencies and the integration between those agencies is going to be critical, regardless of where healthcare is being provided, rural, urban, or otherwise. But some of the other things that I think about specifically for rural are really effective regional advisory councils. So the government has restructured our advisory system across the province and really want to see those as truly advisory to government and to the agencies. And that's where local voices can really be elevated and heard. So that's something that I would really like to see us all sort of leaning into and making sure that those are truly functioning in an advisory role. And then from our perspective in government, that we provide a closed loop on those discussions. So if advice is coming forward and government chooses not to proceed with a particular direction, then going back and explaining the why is really important for people to be able to have trust in those functions and those agencies. And then the other thing with rural that I love in this part of my role is that the community gets mobilized in rural Alberta more than anywhere else. And that, while it doesn't seem like it's maybe a government governance type of a model, I think we fail if we overlook the power that comes from mobilizing the community and working collectively with those community agencies and governments together.
Yeah. No, thanks for that. And I do think you're quite right. We often think of governance as some kind of top-down structure rather than actually the collective assets that a community might bring. But Kim, over to you in your new role of any thoughts around the whole governance and organizational structures for primary care, the opportunities that you see or key innovations that you think are needed. Certainly, there's been some issues with the government currently integrating an expanded role for nurse practitioners in Alberta and trying to develop a pathway. But I don't know if you have any comments around governance and organizational structures.
Yeah, and thank you for the opportunity to speak and for everyone who's in attendance today. I really appreciate the opportunity. I think those are really great questions and really pertinent in today's landscape. I think that from my perspective, some of the things that are really going to be important in terms of organizational structures and governance is how we move forward in terms of our teams and in terms of our healthcare providers and how they practice with one another. Team-based care, I think, is going to be really critical for us as we move forward and we look to attach all of the patients across the province, ensure that they have access to timely quality care. And through that collaboration, working together, ensuring that each area and any primary care providers have access to the appropriate health record systems, or if it's Connect Care or others, so that everyone in the care team has access to the information to be able to provide that continuity of care between the providers and to the patient, keeping that patient at the center of that care. And I think we have a really great opportunity with some of the changes that we're seeing to be able to really embrace that and move forward and look at ensuring that practitioners are working to their full scope of practice in a collaborative way.
Okay, no, thanks. And I might actually come back to the nurse practitioner as a kind of operating, I think, independently their own clinic and how we might coordinate that, because certainly it's in other jurisdictions. There's been an expanded role of nurse practitioners, primary care providers moving forward. But Ray, over to you in terms of innovations that you think are urgently required, or maybe you've observed some that are underway in terms of the actual governance and organizational structures, specifically addressing rural health issues.
Yeah, thanks, John. And again, just appreciate being kind of invited into the call. So beaming in from Clecton and Sim territory here in Valmont, which is just across the border from Alberta. So although I'm a kind of a interloper from BC, really appreciate Alberta Health Services, and particularly like our babies are born in Hinton in Valmont, and so we do have that connection. So yeah, appreciate the chance to speak. I got to say I have a kind of inbuilt bias. I'll declare my bias here. Kind of often when I hear governance as a kind of rural clinician, it kind of I kind of want to turn and run for the hills a little bit because and that's not to say governance is wrong or bad, but often it implies kind of boards and Robert's rules and kind of a kind of collective approach to things. And I think that is an important way to do things, but I don't think it's the only way to deal with governance. And, for me, it's very much about decision making and accountability and kind of where those things sit. And so kind of really appreciate kind of the thoughts around regional advisory boards and kind of communities kind of figuring out what works on the ground. I would say something that's always an eternal problem in a rural context, but I think we should be continuing to pursue is really how we kind of allow decision making to happen as close to the clinical interface as it can be. One of the sayings we have is when you've seen one rural community, you've seen one rural community. Every community is different, and so is there a way to actually, in a governance structure, allow local decision making as much as possible? And there needs to be a top down kind of prioritization of these are the things we're focusing on, whether it's primary care or nurse practitioners, integration into professional teams. Those are all super important things, but how they look on community. And so if you can figure out a governance structure that allows, and I don't have the answer to that, I think there are some ways that it can be done, But I think really intentionally thinking about local community decision making and then accountability. What does accountability look like for that? Because you can't have decision making without accountability. I would, if we start a conversation with governance, we'll usually just keep talking about governance forever. So really would encourage us to be thinking about starting a conversation on goals and what we're trying to achieve, and then figuring out what that decision-making kind of accountability or governance structure kind of fits over that. So that's the governance piece. And then organizational structures, often when people look at organizational structures, kind of they would kind of see kind of a corporate organizational structure as kind of the way to do things. And that is very effective, I think, in maintaining the status quo, maintaining kind of a service that's stable. So, kind of a CEO and a C-suite, and then policies and procedures and whatever, and that's kind of an organizational structure. I do think in this time, thinking about networks, and that's obviously a bias. Rural Coordination Center is built as a network, but thinking about networks, and they are a different type of organizational structure. And I think the role of networks in actually making things happen is super important for us to be thinking about as we kind of move forward, because that formal networks and informal networks, but that really, that importance of connection kind of between various kind of groups and people who have common interest, and how do we foster the relationships between them, and how do we foster kind of coordinated action between networks is something that I'd encourage us to be thinking about.
No, thank you very much for those comments. There was a comment in the chat I noted about the defining rural, because I think we often have rural and remote, and I just remember from the last event that we did, and I think it might have been you, Ray, who said if you have a Costco, you're not rural, and if you have a Tim Hortons, you're not remote, which I thought was a wonderful kind of definition.
I did get into trouble with that, John, because I
Oh,
think
do
it
you?
was Costco in the community that we were in. So
Oh, okay. That moving forward. But just following on a couple before we go to the next one, a question kind of in the chat for Wanda. In terms of and I'm sorry I'm going to talk about organizational again, but it just came in the chat of the corridors of care which have been established, I think, and identified of 7 corridors of care. Is the primary care sectors over for you and Kim, are they going to align with those corridors of care in a consistent way, or in particularly the primary care setting?
Yeah, so the intent with the corridors is to be able to acknowledge that generally, not in all cases, but generally, the corridors do reflect the pattern of Albertans' traffic, for lack of a better word, in accessing health services. Less so in primary care than in acute care, because again, those travel patterns are largely related to access to specialists and hospital settings. However, just from a continuity perspective and being able to report outcomes, report data, be talking about the same populations and so on, the corridor structures will be the same that we use in primary care when we're reporting at sort of the macro level. The other thing that we are looking at is how do we transform our primary care network structure and potentially aligning that with the corridors as well. So primary care networks in Alberta right now are not geographically based. So there isn't coverage for all corners of the province. And unfortunately, rural and remote locations tend to be those that are least served by the primary care networks. And so we are looking at how do we make a system that is more geographically based so that there aren't gaps in service, and looking at the corridors for those potential boundaries for that future of PCNs.
Okay. Kim, I don't know if you had a comment on that or.
No, I was just going to speak to in terms of the corridors and the way that the system is going to be set up, and to address the different challenges around access for some of those rural and remote areas. the way that the system is being set up, I think, provides some opportunity for a lot more local perspective to be considered, including those healthcare professionals that are from those communities who best know and support those communities and will be able to best advocate for what those individual needs are.
Right. And one in the chat, and we'll get to some of them later, but just as far as system organization, a real key concern, and I think it's come up from a number of people, is uh, there's local services, but then there's access to specialist services and a significant amount of travel time that might be required people to kind of access diagnostic workup or various things. And Ray, I don't know if there's been some, in your experience, some solutions in that access to specialist care in terms of who travels and who doesn't travel and that kind of thing, or some of the innovations that you think to address that particular burden that exists when you have those highly specialized services and you need to access them and you live in a small rural community.
Yeah, thanks, John. So maybe before that, I'll kind of just jump in on the corridors of care, and maybe I'm really curious, kind of Wanda and Kim, because I think Alberta's a little further on than BC on this, and one of the things we're concerned about in BC is often, particularly in resource-constrained kind of environments, which I think we kind of are looking at this stage.
Yeah.
The worry with rural communities is you're gonna, as they let resources, the resources are going to be pulled further into the corridors. So how do you mitigate against that? Because obviously that's an easy solution, but it's probably not the right solution. I think leads into this question, which is really the burden of travel for rural and the burden of access, particularly to specialist services. So we've done some. So the first thing I think we need to do is actually start articulating that and documenting that. And I know there were some conversations last year around data, but really looking at the data that actually tells that story. In BC, we've been kind of supporting one of the programs we run is real-time virtual supports, which is kind of really providing specialist and specialized access, really kind of using virtual supports to on the ground teams to actually increase access to kind of services, specialist services particularly. And one of the things that we've demonstrated out of that work is in the last year, I think it was $25 or $35 million in cost savings to patients. So avoiding travel, so directly to patients, which is something we don't actually often really account for, because that's not something that is in the public purse necessarily, but that burden is kind of put on patients. And so I think starting to document that is going to be an important part of that story. And I think leads into one of the questions in the chat around quality and how do you assess and really look at a quality framework that actually that works for rural, because we tend, when we're measuring anything, to measure what's easy, and then we tend to do what we measure. So that drives behavior. So really actually thinking very carefully about what's the story we really want to tell. And I think part of that story is rural people tend to have less resources to begin with, and then they tend to spend more. And there's a lot of evidence now around the extra personal cost for rural patients for travel and the burden and the lack of access that happens because of that. And then I think you can start mapping out how you achieve that. So whether it's so we're framing our peer support pathways in RTVS now we call them hybrid health networks, which is really supporting on the ground service, but really looking at bringing teams in virtually to work with on the ground, including kind of specialists and allied health, but specialist services particularly, and then measuring that impact on patient costs and patient outcomes, and also kind of then earlier access to services, or whether it's actually moving supporting specialists to do outreach work. So there is a program in BC called NITOP, which basically supports specialists to travel and do services in rural communities, recognizing that those are, again, in the chat, low volume services. And so, it doesn't make a volume kind of based economic sense, but it actually does make an access based in a longer term cost effective sense for rural communities. And yeah, so there are kind of lots of ways you can look at kind of addressing it as it comes. But I think the first piece is actually to start really starting to tell the story around what those costs are, and
Yeah.
what's been borne by community.
Yeah, and was good. And Ray, I know, and I had put in the link to the forum that we held in June, which Wanda and Ray participated in. There was Sonia, I think, from UBC, but there was a presentation around measurement of equity geographically, and it took a look at the patient in terms of their burden of travel costs and various things like that, which is, I think, important to track and move. Forward. I just
John, if I
my
could just add,
yeah, okay, go ahead.
sorry, if I could just add to that, one of the things that I thought was really insightful at the session that we did have earlier in the year, and I've heard this numerous times around the province when I'm touring and meeting in rural communities, is that the highway runs both ways. So the distance to Whitecourt is the same as the distance from Whitecourt to Edmonton. And there's opportunity for us to be looking at underutilized facilities. And so from a government perspective, that is something that we are looking at. And I see a couple other comments in the chat too around funding models. And that's, again, another sort of unique piece about having this rural health focus in the government. First of all, there wasn't one until we're coming up on 2 years now. Prior to that, there was no acknowledgement of rural health in the government setting, that it was any different. And so across the province, we did have a one-size-fits-all model, which meant one-size-fits-all funding model. And one of the first things that my team raised in our Rural Health Action Plan was that there is an uplift that needs to happen in the funding in order to even get close, not even to achieve equity, but to get closer.
Yeah. Yeah. No, I think that's good. And I know certainly we have provided some feedback too as one moves towards let's say an activity-based funding model as you deliver, say, services in hospital, that certain communities can't provide the activity. They just don't have enough of that activity. So you have to look at quite different models if you choose to have a service there. But Kim, I don't know if you had a comment on what's just recently been said before I go on to the next question.
Yeah, actually, it's really interesting. I was just having a discussion with a group of healthcare leaders yesterday, and we were talking about how we might be able to improve access, whether it's to specialists or other things around child health. And the discussion was looking at different ways that we might be able to do that, including, where can we integrate more virtual related supports where it's appropriate? Where can we look to see where the greatest needs are, and can we send a specialist to some of those communities to reduce the amount of travel burden on hundreds of patients or a number of patients, where you can send one person to some of those communities, and what can that look like, and how can we ensure that we're meeting the needs to the best of our ability within those smaller communities. And so, healthcare providers and leaders and the system in general is certainly seeing this as something that's really important, and looking at different ways that we can, ensure that access is being provided to those rural and remote communities in a way that makes sense and better works for patients.
Okay, no, thanks for that. And the next thing I wanted to ask about is the broad area of addressing health workforce pressures. And I may get to the question in terms of integration of new models and new providers in certain settings, but and maybe I'll start with Ray about the key innovations that you think are urgently required in addressing health workforce challenges in terms of just not having the available kind of staff, perhaps the unique needs of health workforce that are required in rural settings, and what might be some actions that you think might be prioritized to address that particular challenge.
Yeah, thanks, John. I think a lot of what I was going to say has already been said. I know Kim was talking about teams, and I think that's going to be key part of it. And I really kind of agree and appreciate Wanda's comments around that. The road is the same distance kind of either way. And so looking at actually not teams necessarily in the perspective of who's in the community, but who can actually come in, be moved out, and even services. So I know um, we done some work with rural surgical obstetric networks, and Alberta has the rural surgical obstetric networks of Alberta. So that idea of actually, so it's not always the workforce. So the idea of now moving surgical services out into rural communities, because OR time is a challenge in urban. So actually, we've started having urban teams move out to rural hospitals and actually use their ORs to kind of support some of the volume pieces that I think the comments have been talking about. So I think that's the obvious answer. The challenge is it's always difficult to implement that, and I think we talked about this a little bit in the last meeting as well. I think it does need to start with our training because we don't train people in teams, and so it's very difficult to not train them in teams. And then there's also this piece around how do we support teamwork to happen, which requires some different areas of focus and different approaches, I think, to scope. And so I think there's a piece around, and there were some comments around scope with kind of different roles and how we can support that. And I think often the answer to that is everyone needs to be at top of scope. I actually think the solution is we need to do what we need to do to serve the patient in front of us. And so that sometimes is top of scope, but sometimes that's not top of scope. And you need to do the best you can with what you have. I think there's a piece of that. And so I don't think we can talk about teams in rural without talking about generalism. And that's not just a physician, that's kind of all of the team members need to really think about generalism. The Royal College definition of generalism our specialist college in Canada is a great one, which basically says generalism comprises of scope of practice, the team you have around you, and each rural community is going to be a different team, and then what community and patients need. And so then moving into kind of where those circles of the Venn diagram intersect is kind of where we need to go to. And I think supporting generalism is going to be super important as we move forward to addressing health workforce pressures. And it's going to look different in different communities.
Yeah. And I remember actually at our last event, Alika LaFontaine was there, and he was finding it amusing that there was perhaps a subspecialty of general surgery required under general surgery because there's been so many subspecializations that people aren't generalists anymore as it moves forward.
Yeah,
But
and I think the subspecialists have a role, and the specialists absolutely have a role. And the reason I've highlighted the Royal College definition is this is a specialist college definition. And I think we can also look at team as not just who's physically on the ground. That idea of bringing people in virtually or asynchronously to support the people on the ground is super important.
Yeah. Okay. Wanda, I don't know if you had any comments around your challenge with addressing health workforce issues, I think a lot in your role, but I don't know if you had any comments of any innovations you think are urgently required or that you're really trying to drive through right now.
Yeah, thanks, and appreciate Ray's comments too around this topic. And I think most people here would know that we are advancing with training in Grand Prairie and in Lethbridge. Not truly rural, understand that, but much more out in communities where it's going to draw people from rural communities around those locations for training. I grew up north of Grand Prairie, and I never in my wildest dreams thought that there would be medical school being offered in Grand Prairie. So it is groundbreaking. It is innovative. And the other piece that goes along with that then is how do we train people in a team-based care model? And so one of the things that we are working on is interdisciplinary training centers in Grand Prairie and in Lethbridge to be ready for those graduates that are coming through so that they have the opportunity to train in the model that we want to try to advance across the province to deal with some of the workforce challenges.
Yeah. And Kim, I don't know if you have any comments. Certainly there's a great need for all sorts of healthcare workers, but any kind of issues around health workforce pressures and some urgent priorities for you?
Yeah, most certainly. I think, and I appreciate all the comments prior. And to build on some of that, I think, from the nursing lens, there's some great opportunities. We should be ensuring that our healthcare providers, not only nursing, but in many cases, nursing specifically or to work to that full scope of practice, because in many cases, our nurses are not working to their full scope of practice. And that's really important and really critical. There's lots of different opportunities, for RN prescribing, with the new funding model for NPs, there's a ton of opportunity here. And I think we really need to leverage that. I think one of the biggest challenges that we need to face is the issue around different providers feeling and healthcare professionals feeling territorial over their work. It's a big challenge that I've experienced at multiple levels of nursing and have seen it in broader landscapes. And so there's enough work for everybody. And so how do we work to full scope without without minimizing other professionals and other providers' abilities to work to their full scope, and how do we work together? And as Ray mentioned, there's not a lot of training that's been involved in that, and there's the pieces around accountability and what that looks like. And so, I would love to see us be able to move together as a province and a nation to be able to really utilize those full scope of practice, looking at ways to expand practice where appropriate, and that way ensuring that patients can see the right provider at the right time, and potentially reduce the burden on some of the other practitioners. It may not always be that a physician needs to be the first point of contact for a patient in primary care. It could be a nurse, it could be obviously a nurse practitioner or a PA. But in some cases, there might be opportunity for whether it's pharmacy or nursing or whichever, to be able to have some of those initial conversations and communicate and collaborate within that interdisciplinary team to determine the best way to support that patient in their care.
Yeah, and Ray, I'm going to go on to. I don't want to get Wanda to engage around other health professionals, particularly there's a lot of comments around mental health, which I think is important that we focus a lot on mental on healthcare delivery services, and so I'm going to talk a bit about mental health. But in terms of the physician nurse practitioner, um, uh, kind of tension, because some areas it seems to go extremely well, in other areas there's a bit of conflict. But Ray, I don't know if you had any lessons in the growing role of other providers, like being able to prescribe and various kind of things, and any approaches that you think that would be useful to guide beyond education, which you've mentioned, that might help guide to reduce those tensions and conflicts that might occur.
Yeah, so I would say, first of all, we train nurse practitioners in our clinic here. So we have nurse practitioners coming in through training, and I've worked with nurse practitioners in the UK and here. Obviously, our team involves nurses and kind of some allied health. It's intermittent as to who's in community. So I do agree, Kim, that there's enough work for everyone, and yet there is also absolutely this tension kind of between. And I know physicians are often kind of in there around, well, kind of that's our job, and nobody else can do our job. With prescribing, and we've seen this with pharmacists prescribing here in BC. One of the concerns that's often kind of raised by docs is prescribing is done, but then the follow-up's not done. So if you're going to have one piece, it's kind of like the decision making and accountability. If you're going to have one piece, you need to take responsibility for the whole thing. So that's a conversation that needs to happen around, if we are going to be doing different roles, then we need to also be following up. So that's often mentioned, and it absolutely depends on the context, whether that's an issue or not an issue. So I've seen places where it is an issue and where it's not an issue. I think ultimately the approach needs to be a relational approach, because I think as long as we're having conversations about doctors and nurse practitioners, or doctors and pharmacists, or nurses and physiotherapists, or whatever, we kind of really objectify, we dehumanize each other, and then we kind of start getting positional. So I think the approach needs to be kind of a relational approach where we're actually having conversations with people as human beings. And probably the main place that that needs to happen is in community. So around, hey, there is a nurse practitioner in community, and or a midwife, or pharmacist in community, or virtual pharmacy services. And so now, how do we kind of juggle in our context the best way that we can actually meet our patients' needs? One of the biggest challenges in small rural, like our community is 1,100 people, is kind of certainly from the physician side, and this we've wrestled with having a nurse practitioner, and I'm having ongoing conversations in our community. Is our base role is we need enough docs to cover 24/7 emerge. And so there's a bit of primary care that's involved in that, but there's kind of emerge stuff in that, and so having kind of people taking pieces of that away without kind of being able to cover the whole is a challenge. And so I think there needs to be kind of an honest conversation around what does that look like in the community, and do you have capacity? Are there things that can be kind of pulled out where somebody can come in and not necessarily be able to do kind of the full service, but kind of be complementary? And I really think that it needs to be a case by case conversation.
Yeah. Okay, no, thanks. And Wanda, I know from past discussions with you, you've often said it's the same people, and frankly, not putting barriers into what might be collaborative relationships that might be able to occur at a local community level. But besides the education and training, I don't know if you wanted to have any comments regarding ongoing adaptation in terms of looking at scope of providers at all. Alberta's been pretty advanced in my perception compared to a lot of other provinces in expanding scopes for providers.
Yeah, I would agree. I think that we're leading the way in a lot of that area. Where I think that we're lagging, though, is actually bringing Albertans along with us on that journey. Do they know what a nurse practitioner is? Do they know what a nurse practitioner can do? I'm not sure that we've done a very good job in addressing that. And even as we talk about primary care providers and changing our terminology, that we're not just talking about physicians, we're talking about primary care providers. So we're encapsulating, including the pharmacists as well, and helping to educate Albertans around what the services are that each of these primary care providers can offer. I think there's a huge opportunity there as we continue to grow the nurse practitioners in their autonomous practice. I think there's a tipping point that we're going to get to where there's still going to be Albertans that are seeking a primary care provider, but they will be seeking a physician because they maybe don't know that a nurse practitioner is another really good option. It's not oh, well, I don't have a physician, so I guess I have to go to a nurse practitioner. They should be looking at those as comparable services. And it's going to take maybe a generation even to get through that. In speaking with seniors and some of the information that we have anecdotally, they do not want a nurse practitioner. They're not familiar with that.
Right.
But they're familiar with the concept of a physician.
Yeah. If just I might go on to just a quick round of talking about capitalizing on technology opportunities, and certainly post COVID, everyone said there were lots of things that we couldn't do virtually, and all of a sudden we were able to do it quite rapidly in those particular changes. And so are there any kind of innovations that we should be cautious on enthusiasm for, or that we should urgently really uh, uh, take the reins on and move forward? Because I know there's been some fear of some advances in virtual care that might have occurred during COVID, the system's kind of retreating back quickly. But Kim, first to you, in terms of capitalizing on technology solutions like virtual care and various aptitudes, what are some priorities that you think we should really push forward urgently?
Well, I think one of the biggest pieces that we need to recognize is virtual care doesn't mean it's less it's a lesser quality than face to face. There's a time and a place, And I think that the option for virtual care can certainly take a burden off, our ERs and different things. If we look at HealthLink and some of the services that HealthLink offers to Albertans, I think a lot of people don't know necessarily how many services and supports are available within HealthLink. But being able to call in and be able to have access to, if you need a physician, or a primary care provider, there is access for that. But there's also, mental health and counseling. There could be connections to physio and other supports. And so there's a whole robust network within that virtual care option. And that's just one option that we have, within the province. So I think there's a lot of opportunity to look where it makes sense to implement technology. You obviously want the right technology for the right service. It's not necessarily going to work for all things. But there are certainly huge opportunities to be able to provide that access, especially if you look at, rural and remote communities, or just people who have mobility issues or not able to access transportation or things like that. There's definitely a big place for that. And I hope that as we move forward, we can see that more normalized and more utilized. And the idea that it's another option for great quality care.
Okay. And Ray, I don't know, what are some key things if we were wanting to capitalize on technology opportunities, that particularly information technology opportunities, what might be some key priorities that you think should be just urgently driven forward?
I spoke about data, and definitely agree kind of around virtual care. One of the fears with virtual in rural communities is that ultimately it's going to be seen as a substitute for in-person on the ground care. And so I think that needs to be paid attention to. But I think there are absolutely ways that virtual can enhance. And again, if we take a team-based approach, so I've spoken lots about that, to bring a team in virtually around people on the ground, kind of in rural communities. There's some comments about AI, kind of it comes into the technology thing, and I know there was discussion about this earlier on. I don't think the question is, can AI influence how healthcare is delivered? I think AI will and is already influencing how healthcare is delivered. The question is, do we kind of at least drive that in a way that it works for rural and works for kind of healthcare delivery? So that's something we need to pay attention to. I don't know what the answer is on that, but I think it's not something that's optional. It's coming in and is already influencing. So those are the two pieces I'd kind of maybe add to the conversation.
I do think. And Wanda, I don't know if you had any comments on the technology component.
Yeah, I get proposals sent to me on a weekly basis from the private sector. There are a lot of products out there, and I will use this opportunity to put in a plug for my friends at Primary Care Alberta and HealthLink 811, because nobody has been able to provide a proposal to me that shows something that's better and more cost effective than what we have with 811 right now. So I would love to see that expanded and optimized, because I think it actually has the trust of Albertans too. And that's a big piece when I talk to some of these companies, that how are you going to get the trust of Albertans? This is their most sensitive information, their most personal information that you're going to be holding. And how are you protecting it? And it's a very important question that few have answered. And do I trust some of them? Some, not all, but I trust 811.
Yeah. Well, I do think actually, I remember I was once asked about what were the two most important things to do with reform in the healthcare system, and people were doing very technical things, but I highlighted trust and kindness are two powerful things, and they often get forgotten. But particularly trust is a very important and powerful tool, I think, in what the public might accept. I might just go on now because I had asked the panelists to consider, and we might have a last couple of questions too. But I was wondering, in the area of rural healthcare, and you're all embedded in it and delivering and trying to improve it, of what's your biggest hope and your biggest fear in addressing rural healthcare needs over the next period of time? What do you go, oh my God, I'm fearful of this, or oh, this is what my big hope is. And I don't know, Kim, if it's okay, I can start with you on addressing that question.
Yeah, absolutely. I would say my greatest hope in addressing rural healthcare needs is really the successful implementation of team-based care across Alberta, where all providers are working collaboratively and effectively to their full scope of practice, and where we can see those measurable improvements in patient care as a result. And in terms of my biggest fear, I think it's just that, that rural communities uh, continue to be viewed through that urban lens, leading to that one size fits all approach. And I certainly hope that as we have made some of the changes that we're currently experiencing now, that we are moving away from that. But it's certainly been, as others have discussed as well, a challenge in the past.
Yeah. Okay, thanks. And Wanda?
Thanks, John. So, my biggest hope is that rural communities um, become healthier. And in 10, 20, 30 years from now, this isn't the same conversation that we're having. And my biggest fear is just the inverse of that, that we are still having this same conversation 10, 20, 30 years from now. And I say that in the context of the work that my rural health team did when we first stood up the branch, which was just go onto the internet, see who's doing what in rural health. What do we know? What are the challenges? And we found reports back to the 80s that were talking about the exact same things that we're talking about today.
Yeah,
So that's my biggest fear.
it is in action. And certainly I think the focus on, and I think it's been brought up before about measurement and reporting, because knowing how healthy the particular population is in the particular various regions, knowing the burden on them, and I think that's something the public can't react to things that they don't know, and so that transparency of what the situation is, I think, is important. But Ray, what is your biggest hope and your biggest fear in addressing rural healthcare needs?
Thanks, John. I'll keep it super short. My answer, I've been thinking a lot about this. My answer is actually one word, and it's the same word for both. It's change. And, I think we're undergoing transformational change because of economic pressures, societal pressures, technology pressures. So I do think we're on the verge of transformational change. So that incites a little bit of fear in me because often when there's big change, the have-nots get less because people tend to kind of pull back and kind of just deal with kind of the averages, which doesn't work out for rural. So that's my biggest fear in kind of this time of transformational change, that rural will either be, as Wanda said, in the same position we were 20 years ago, or even worse. My biggest hope is that innovation occurs at the edge, and we often look at rural as a deficit kind of place, but rural is very good at adapting and changing quickly and actually leading out. So there is an opportunity in transformational change if rural is looked to as a leader in a place where ideas are incubated and actually solutions are found, that actually in that change, this whole system could be better because of rural and it'd be better for rural as well. So that would be my biggest hope.
Oh, no, thanks for that. Because I know in past conversations, um, and I don't know if it was with you, but with other ones of where we're trying to move towards team-based care and move towards integration. And in rural healthcare settings, it often happens by necessity because you must do that in order to deliver the services. And the comments that you make, I think, are very well founded about looking at from a strength-based approach as opposed to a deficit approach. And are there misconceptions about rural healthcare that you think urban dwellers or other people have had? And I don't know if anybody had any kind of thoughts of things Wanda, as you've now worked in the portfolio, you lived and you came from a rural community, I think, so you came with that understanding. But are there misconceptions about delivery situation in rural healthcare that you think might be useful to highlight? I don't know if anybody has a particular comment on that.
I have maybe an anecdote.
Okay.
Um, so I don't know if we have anybody from Northern Alberta on the call, but I hope we do. So I was born in Fairview, grew up in a place called Hines Creek. So the closest healthcare was in Fairview, and Grand Prairie, of course, was the closest sort of urban setting at about 2 hours away. So most of my specialist care that my family or friends would have received would have been in Edmonton. And as I'm, in this rural health portfolio, there's been discussions about some services in Fairview. Fairview's a hospital that has an emergency department that closes on a fairly regular basis. And one of my colleagues said, "Well, there's nobody north of Fairview." And I said, "Well, I think my family might take offense at that." So it was just interesting because they were kind of looking at a map and looking at sort of where do we have healthcare facilities. And so if there isn't a healthcare facility north of Fairview, then nobody must live north of Fairview. And so that to me is the change in dialogue that my team has been pushing, that I've been driving at executive team tables as well, is there are Albertans that live in all corners of this province, and they are all taxpayers and they all pay into the system. And so how are we serving them?
Yeah. And I don't know, Kim or Ray, if you had a follow-up comment on Wanda's comment. I do think often that rural is often seen as rural healthcare is seen as a hospital too. I think sometimes in terms of that particular perspective. But any misconceptions that you think people have about rural communities?
Go for it, Kim.
I was just going to say one of the things that I've experienced throughout my career is the perception sometimes that rural care is less quality or there's less knowledge, and that's been something that we've worked really hard to try and combat, because some of the greatest healthcare providers that I had the privilege of working with were from rural communities, and to have faith in your team that no matter what comes through the door, there's knowledge and skills that are able to manage and to get patients to those, other centers where they may need services that you just can't access in the rural communities. But the care and the knowledge and the expertise is fantastic rural as well.
Yeah.
Yeah, and just briefly from my side, John, so certainly Wanda, totally agree with you on the way the healthcare system's seen. And so I work in the diagnostic and treatment center where we do 24/7 emerge coverage. So it's not a hospital, there are no inpatient beds, but and then there's nursing stations. And so actually there's lots of places where care is delivered in rural, even though it may not show on a map with a certain lens. And the integration and longitudinal kind of continuity of care, the opportunities in some rural places is way better than in a lot of other spaces. So I came here because I wanted to deliver the babies I delivered, and there's value in knowing a community, knowing kind of families, and knowing context, and kind of walking the road, as my colleague here would call it, with people. That often happens in rural, and that may be a doctor, it may be a nurse, it may be MOA, but actually knowing kind of people and being known, I think is one of the big value adds of rural, and often is overlooked because it is a quality a predictor of quality.
Yeah. Well, no, thanks very much. I'm just putting in the chat again, just a link to this past event that we had in June, which people might want to go look at because we're able to record that. And we're going to be sharing this discussion, but also stay tuned because we're planning a rural health policy forum to focus on issues. And I find that rural health policy is often a stream in a larger, gigantic conference rather than really focusing on the particular issues moving forward. So we're hoping to move forward on that in 2026. But please join me in thanking our the governor, Aubee, but Wanda, and Kim and Ray for their thoughtful contributions, and people who I think are really doing great efforts to guide rural health policy. And thanks for their knowledge and sharing and insights. Thanks very much.